Thanks, Adam. We're looking forward to this next speaker, having had 2 microdiscectomies on my back. The next speaker is David Johnson. He's a back injury rehabilitation specialist. Dr. David, this is a bit wordy, so bear with me. Dr. David Johnson is a brain and spinal neurosurgeon who has a pioneering role in the establishment of multidisciplinary spinal practices and holistic care for neurosurgical patients for over 20 years. Dr. Johnson has a particular interest in comprehensive spine pain management and is a leader in the field of surgery and rehabilitation for the epidemic condition of lower back pain. Dr. Johnson is an Olympic weightlifting coach and nationally competitive, highly ranked functional fitness athlete, finishing top 10 in Australia from 2021 to 2024 in the CrossFit Games Worldwide Open. In 2024, he was a CrossFit Games Masters semi-finalist. His passion and pursuit for elite lumbo-pelvic biomechanics has enabled him to establish the Functional Movement Training Centre in 2015. This is the first specific and distinctive spine rehabilitation centre which addresses the disease of movement dysfunction, a term he coins to emphasise that the epidemic levels of spine-related lower back pain must have a reversible root cause. He has aided in the recovery of thousands of patients with chronic back pain and neck pain by following this paradigm. Dr. Johnson is the first clinician in the world to publish the clinical model which describes the cause for low back pain symptoms and has published broadly across many back pain related issues. Put your hands together for David Johnson.
Good afternoon, everyone. How are you going? Thanks very much for inviting me along, Shelley, and congratulations on having a fantastic event. It's a pleasure to be here. I'll have to get my personal assistant as well to reduce that intro. Sorry about that. All right, well, we're going to talk about back pain today. Nothing quite as exciting as multi-trauma and cybercrime, but I think equally important. So on that note, how many people in the room have experienced an episode of low back pain? It's almost everyone. And as in your professional lives, how many have attended a call out for someone who has collapsed at home and has severe back spasms and couldn't possibly survive at home without coming to the emergency department? I've seen thousands of people with back pain, and it is really incredible how many people present to an emergency department with back pain. So let's talk a little bit about back pain today. Okay, forward. I've actually done a bit of work with, and our team, our organisation, had done a bit of work with the QAS and paramedics before. I think it was around 2018, 2019. Thanks to a fellow by the name of Kevin Hall. I don't know if Kevin's here today. He was sort of working in the Sunshine Coast district, but we identified that back pain was a pretty significant cause of personnel injury, paramedic injury, back pain. And we started to set about an education program for paramedics to reduce the incidence of low back pain. And I think we were pretty successful. We had a very high appreciation rate and feedback that the things that we were educating them about back pain and preventing back pain and understanding the cause of low back pain was able to be utilised in the field. Maybe there's a possibility of revisiting that in the future as well. And we also identified that QAS and paramedic officers really fall into the category of profession similar to Defence Force, police, fireys, where every day that you go to work, it's a little bit unexpected. You don't really know what you're going to be faced with. You may be faced with a bariatric patient weighing 150 kilograms in a bedroom that has a staircase to negotiate to get her down. or it may be a really simple day and everyone's quite easily managed and mobilised. But because of that unknown factor, there's an element of general physical preparedness that's required, and you need to be capable of different domains of physical ability: heavy, light, fast, agile, awkward positioning. And during your normal course of work, you need to have a stable lumbar spine to avoid injuring it. So if we're going to develop an effective rehabilitation program, we need to not only be able to effectively rehabilitate a spine injury, but we want to prevent injury as well. And secondarily, we want to enable a fairly high level of functional capacity to meet the everyday demands of your work requirements. So how do we do that? Well, you really need three elements. You do have to be able to control the symptoms of pain. As a surgeon, there are unfortunately circumstances where there's excessive structural injury. There may be spinal cord compression, nerve root compression, structural instability of the spine, deformity. And in those circumstances, surgical structural repair is necessary. Okay? Most people want to avoid surgery. And the other element of the overall management of back pain is this rehabilitation and implementing the most effective form of rehabilitation for back pain. And ideally, if we can have a high level of injury prevention and a very high level of injury recovery, we're going to be able to prevent the need for surgical structural interventions. Now, how do you address this optimal rehabilitation? You really need to have a cohort of people that understand this concept of the causation for your low back pain symptoms. And slowly over the years, we are developing more people that are understanding this paradigm, and the discipline that I assign to that expertise is in terms of rehabilitation, it's a functional movement therapist. And a functional movement therapist can be from any discipline of physical rehabilitation. They may be an osteopath, they may be a physiotherapist, they may be an exercise physiologist, chiropractor, and I've trained many. But one thing that they all have in common is this understanding of lifting biomechanics. And from my intro, as kindly described, a passion of mine is Olympic weightlifting and functional training. And a huge part of that experience is lifting heavy things lots of times and quickly, which kind of gives me that insight into how important that is in terms of maintaining a healthy lumbopelvic spine. So one of the things that is in stark contrast to a lot of the back pain therapeutic industry is when we talk to patients who present with back pain, we actually say, we're not going to treat your back pain. We're going to treat the cause of your back pain. And if I effectively treat the cause of your back pain, then over a short period of time, there will be no requirement for symptom-based care. But if you don't have that approach from the outset, and a lot of the industry is that way inclined, this is what you need to do to treat your pain symptoms. And they actually don't have a paradigm for addressing the cause. And in that circumstance, you will, for an indefinite period, continue to need to address the symptoms. And typically over time, the potency of those symptom-based interventions increases from simple old over-the-counter analgesia like Panadol and Nurofen. And then as time goes on, you need more of it, and then the class of drugs starts to go up into the opioids, cortisone injections and more and more. And so that's the classic narrative that would result without addressing root causation. And that's really not following one of the critical tenets of medicine, which is a cause-based model for disease. We should always focus to address causation in conjunction with symptoms, and then that's curing the disease that causes the symptoms. Okay, and that's how we generally practice medicine. But for some reason, in musculoskeletal medicine, and in particular, the condition of low back pain, we've kind of turned a blind eye to causation. And this particular paper, which is widely quoted within back pain research, it's one of the most quoted articles published in The Lancet, of course. It clearly says in the first paragraph in the abstract that low back pain does not have a cause, and that is a blatant mistake. It's turned the whole industry's brains off to understanding causation, and it's kind of a little bit fundamentally ignorant of the fact that you cannot have an epidemic condition without a relatively simple root cause. They go hand in hand. By definition, epidemics have to have a root cause. And if you think about your experience, maybe not so much on a day-to-day circumstance, but in general, and I certainly see it every day at work. I have my own private patients. I do medico-legal work. I do work for insurance companies. I read a lot of expert assessments of people with back pain, and to date, I have not yet read one single report from all of those disciplines that has described the quality of movement of the patient who presents with low back pain. Okay, not one, and the whole industry from corner to corner, including physical therapists, do not describe the quality of the movement that the patient displays. They'll very commonly describe range of motion, they'll describe muscle wasting, they'll describe hypersensitivity, limits of movement with tenderness, and those types of aspects, all of the neurological findings that we do on clinical examination, very well detailed, but they won't actually talk about how well a patient stands up from a chair, how well they sit down from a chair, how well they bend over to pick up a mobile phone or their glasses off a coffee table. And that's a big problem because they are ignoring functional movement proficiency. And if you look at the data, it doesn't take very long to do a little bit of a review to identify that we're kind of, as an industry, we're kind of doing very badly at addressing this condition. And this is the latest burden of disease study from the Australian Bureau of Statistics, and I think it goes back from 2003 to 2018, and during that period of time, resources for rehabilitation just increased phenomenally. There's a physiotherapist on every street corner. I think there's 40,000 registered physiotherapists in Australia. Services are subsidised by the government to receive rehabilitation at no charge. But in actual fact, the prevalence of back pain increased in that period of time. Okay, the incidence of ischemic heart disease deaths and coronary events decreased, but little old back pain, which is second there as the leading cause of disease burden, went up in that period of time. So there's absolutely no doubt that we need to improve on the paradigm of care for this pretty ho-hum boring condition of low back pain that everyone in the room has experienced. There's more information from the WHO if you listen to anything that that organisation has to say. Now, this is just a table that kind of depicts the algorithm for someone who would present to their general practitioner with back pain. The general practitioner has two paths that they can follow. There's a surgical path and a non-surgical path. Now, most people who present on their initial episode of low back pain are not going to be directed to surgery. It doesn't necessarily mean that that's not the best option, but it's obviously the most invasive, expensive and a risky option. So surgery is generally held in reserve for as long as possible. And so you clearly move down these other management strategies. The first one is usually, a work certificate, take a couple of days off work, start off with some simple analgesia, work your way up if necessary, come back and see me if it's no better, and we'll give you some stronger medications. And then you work up the cascade to physical therapies, which is, pages and pages of long of options. All the opathies, chiropractic therapy, physiotherapy, osteopathy, Bowen therapy, Pilates, acupuncture, dry needling, wet needling. I don't even know what half of these things are. But it's all out there, and all my patients tell me every single day they've all done them, and I'm not getting better. But one thing that is very scarcely provided to patients is a restoration of their movement quality. And that's a common question that I'll ask my patients. Did the therapist that you went to see for the last 5 years, did they ever talk to you about your movement quality? And it's just the same thing every time. They don't know, what are you talking about? What do you mean by movement quality? And if the patient doesn't have any concept of movement quality, then they have definitely not received any form of functional movement training. Okay, and that really needs to be the centrepiece. All the other things can revolve around that, whereas the movement quality of their lumbopelvic spine is the actual centrepiece of what their care should be. It's a little bit like saying to someone, with pneumonia, yes, we'll give you a lung transplant, but you can keep smoking. Or someone who's having a liver transplant for cirrhosis, you can have a liver transplant, but it's okay if you keep drinking. And that's kind of what we're doing with back pain. We're allowing them to have repetitive symptom-based treatment, but always allowing the cause to remain unresolved. And so we all know that paradigm of management is ultimately going to fail and result in this epidemic situation of back pain. And the opioid crisis that we talk about all the time, the opioid crisis is really just a musculoskeletal back pain crisis. Okay, back pain is the highest, most prevalent musculoskeletal condition. And effectively, if we could improve the prevalence of back pain, the rate of opioid requirement would reduce dramatically. But we kind of phrase it as an opioid crisis, but we don't talk about why so many people are requiring opioids. It's because of their unresolved chronic musculoskeletal pain. Okay, so it should be talked about in the same breath. Not just, okay, this is the opioid crisis, we need to stop prescribing opioids. We need to stop the pain breaking through society, that of course living with pain is intolerable, and of course they will seek out opioids to control the pain. To just say, well, you can't have opioids because there's an opioid crisis, it's kind of a little bit cruel. Okay? We recognise the harms of opioids, but we also recognise the harms of living with chronic pain. I would advocate that we should address the chronic pain situation, and the opioid crisis will disappear. So when we're talking about the spine and any joint, in fact, the most important thing that determines the health of the joint, not just your back, is stability. The lumbar spine just happens to be a stack of vertebrae stacked on top of each other with lots of joints. Every motion segment has 3 joints: the discovertebral joint and the 2 facet joints. Okay, so it's a tripod joint, and the same principle applies to the back as any joint. The most important thing that determines joint health is the stability of that joint. Okay, so stability is a really important word, and we kind of all understand what stability means. You know, if you've got a toddler and he's learning to ride his bike for the first time, if he's unstable, he's going to fall off. He's going to, you know, it takes him a few goes before and Dad will hold the back of the bike seat and just make sure that he's stable so that he doesn't fall off. And so that general life experience of stability applies also to spinal joints. And there are important factors that determine whether your joint is stable. And we kind of knew this back in the 90s when a biomechanical researcher called Punjabi described the principles that are required for stability of the lumbar spine. Okay, but we've kind of moved into this new era where stability is a bit ignored because we didn't really focus, the industry didn't really focus on the effective way that Punjabi described to create stability. And there's only three elements that determine the stability of a joint, and that's what he described as the active elements, the passive elements, and neural control. Okay, and active elements just means contractile structures around your joint. So that is the muscular elements. The muscular elements are the only contractile elements. And then the passive elements are all the other non-contractile soft tissues, the periarticular soft tissues, such as your ligaments, your tendons, your joint capsules, the cartilage in your disc, the bones themselves. Okay, so they're all the non-contractile elements. Of course, they're important as well. And the final element is this thing called neural control. And neural control really means the central nervous system's coordination of the way the active and passive elements work together. Okay, and in actual fact, the neural control is the most important factor of those 3 elements because it determines how well the joint moves. It doesn't determine how powerful or strong the joint is, but that's a secondary discretionary choice about what your functional capacity demands are, what the functional demands on your life are. So the picture there of the strong man versus the weak-looking man, I actually say to my patients who've been doing a heap of exercise therapy, a heap of core strengthening, a heap of Pilates, I actually say, well, I would actually rather you be the weakest person with the best neural control of your joint, rather than a strong person with poor neural control. Because the strong person with poor neural control will eventually develop joint-related pain, and once they develop joint-related pain, they're going to actually become weak anyway. Whereas the weak person who's moving with good neural control and good biomechanical proficiency will have very healthy joints, and they will be able to discretionarily choose whether they'd like to increase their functional capacity to engage in a lifestyle activity as they please. Okay? But most people just don't want to have pain. Okay? That's the first thing, because that's what a patient is coming to see you with. When a patient knocks on my door and says, please help me, I've got back pain, they don't want to get a six-pack. Okay? And yet most people who go to a physical therapist now go there because they've got back pain, and 6 months later they leave with a six-pack, but they still have pain. Okay? That's not what they went there for. They didn't go there wanting to get fitter. Okay, so exercise is not the right term to use. Exercise therapy and core strengthening is not the right term to use to restore the condition, the clinical condition of back pain. And so I refer to the neural control as being like the concrete slab of your joint health. Once you've got that concrete slab, which is essential, you can either build a garden shed on it or you can build a palace. If you don't have that concrete slab, you can't. The whole system is going to crumble. So neural control is of primary importance, and that's one of the key elements in understanding causation for back pain and the kind of paradigm shift that we all need to take industry-wide to start to eliminate this epidemic of low back pain. And another way to visualise that concept is looking at this slide here. Most people would say, hey, yeah, I'd like to get from A to B in the Rolls Royce, thanks, not the old Humpty Dumpty car there. But why? Because you're thinking that that's the most structurally attractive vehicle. But when you thread into that conversation or that decision making, the coordination and quality of the driver, the Rolls Royce is being driven by the drunk driver versus the bomb being driven by a very good limo driver, I'm going to jump in the bomb because I'm more worried about the control of the vehicle. Okay, and that's the same sort of principle described there. So defining the disease that causes back pain, and I just coined the term movement dysfunction in regard to back pain. It's movement dysfunction of the lumbopelvic spine. And so movement dysfunction can be considered a disease process in and of itself. And it's an acquired, ubiquitous, functional disease of modern industrialised lifestyle manifesting with musculoskeletal pain, disability and structural compromise. When our little toddlers first learn to play with their toys and their Lego and their trains and they squat down, they don't yet have movement dysfunction. When you go to non-industrialised societies, and I've travelled to northern China, Africa, Papua New Guinea, they also don't have very high levels of movement dysfunction. And they don't have very high levels of low back pain. But when you observe the rates and prevalence of low back pain in modern industrialised lifestyle, it's very high, and almost everyone has movement dysfunction. I did some research where I went around our tertiary hospital and I just gave 30 people a simple bending task, a very simple bending task. And we identified that all but 2 patients performed that simple bending task biomechanically poorly. Okay, they didn't get back pain at the time of doing that research, that task, but the repetition of that poor biomechanical bending over time will increase their susceptibility to that smoking gun moment when they cough or sneeze at home, or they go to put their socks on and they just get that massive back spasm and then call you guys to take them to hospital. Okay, but it's actually it's a legacy of their preceding poor biomechanical movement dysfunction that has led them to that smoking gun moment. The killer couch that they shifted for their neighbour who's rearranging their lounge room. Okay. So how do we restore joint stability? There's only 3 ways to re-establish stability. Okay, I like to group things into 3 because I can't remember much more than 3 things. So I've already talked about the rehabilitation of functional movement proficiency. We can restore joint stability by putting titanium across a joint, okay, a new knee joint or a new hip joint, or a spinal fusion or a disc arthroplasty. Yes, that will restore joint stability, and that's why we do it in those patients that are beyond effective rehabilitation. And then the third thing is to tell a patient to do nothing. Okay, think about a patient who's just had a motorbike accident and they've got a teardrop fracture of their C-spine, or they've got spinal tenderness and stiffness, and what's the first thing you're going to do? you're going to put a collar on them, you're going to immobilise them. You're going to tell that patient to do absolutely nothing. And that's one extreme end of the spectrum, but at the clinical level, people are kind of applying that principle. They are not going to work anymore. They'll get the gardener in to do the whippersnipping. They'll go into workers' comp. That's the real life extreme of regaining stability by doing nothing. Okay, and I call that Oprah therapy or Netflix therapy. They just watch Netflix or play computer games. By reducing lifestyle demands, they can improve their stability. But it's a maladaptive way of addressing the problem. Okay, so that's all you need to think about. There's only 3 approaches: do nothing, get stabilising surgery, or in a timely way. If you get your rehabilitation at an early stage, you can regain stability. Of course, we have to deliver the therapy early. If you have back pain for 20 years, there's many other physiological things that emerge. And so when patients tell me that sort of history, I say, look, we can go through the process of restoring your stability, but because it's been 20 years, there's going to be a lot of other physiological overlay. And one of the key things that occurs, even within as short as 6 to 12 months in patients, and depending on some of the social circumstances around the injury, is this condition of central sensitisation. And if we don't address the back pain in an effective and timely manner, then we also have to start to address this secondary neurological condition called central sensitisation. And no matter, even if I did the most effective keyhole, minimally invasive spinal fusion with no complications, and if a patient had central sensitisation, when I saw them 6 months later, they would still say my back pain's killing me. Because yes, I restored their spinal stability with the surgery, but I have not addressed the neurological condition that's within their central nervous system that continues to create this hypersensitivity complex and debilitating low back pain symptoms. And that's when this horrible circumstance arises where the surgeon says, look, I've done the best spinal fusion, look at the x-rays, they look great, I don't know why you've still got pain. And then they just say, no further, there's nothing more that I can do for you. And we call that failed back pain surgery syndrome. Okay, it's actually not failed back pain surgery syndrome. It's just a failure to address the back pain in a timely manner and a failure to address central sensitisation. The surgery met all of the criteria that it set out to, but we just didn't implement the rehabilitation strategies early enough, and we ignored central sensitisation. So I actually call that failed back pain rehabilitation syndrome. Okay, and a lot of people don't like that because they don't like to have the finger pointed at suboptimal rehabilitation. There's a lot of people that get their noses out of joint. But if you can have a condition of failed back pain surgery syndrome, you can very well have a condition of failed back pain rehabilitation syndrome, right? And this is what happens to the spine when you ignore the lumbar-pelvic biomechanics over a period of time. You get all of those things that are described by the radiologist on the images, facet hypertrophy, facet arthritis, facet arthropathy, modic changes on the MRI scan, the disc desiccation, the disc bulges, the annular tears. That's all a secondary consequence of poor movement. And don't confuse that from normal degenerative changes, okay? If I go to northern China and pull out little old grandma who's been squatting and moving and walking and toiling her whole life and has no back pain and put her into an MRI machine, she's going to have all of those degenerative changes but none of them are inflamed. None of them are inflamed. None of them are behaving as nociceptors. And so therefore that is truly representative of age-related, normal, healthy degeneration. Contrast that with a 30-year-old who's been moving poorly, working as a labourer, and never had any workplace health and safety or lifting training, who has a little bit of degeneration and is in agony and on opioids and can't work. Okay? That is not degeneration. That is accelerated degeneritis. Okay? And I like to add the word degeneritis or the itis to imply inflammation is active. Inflammation. And so degeneration and degeneritis are two completely different things. And the thing that divides them is whether the individual has this disease of movement dysfunction. All right? And so if you want the rules of what good movement is on paper, we can write down the rules. Just like if you open up a new board game, the first thing you go to is the rule book and read the rules. If you want the rule book for having a healthy lumbopelvic spine and avoiding the development of low back pain symptoms, there they are. There's really only 5 rules. Okay, the most important ones are in that order: hip-centric rotation, neutral spine maintenance with torso inclination, unloaded knee positions, and posterior kinetic chain activated movement. Okay, those are the basic principles of the biomechanics that apply to having a healthy spine. And that's also what I will teach to someone who's wanting to learn how to do an Olympic clean and jerk or to do an Olympic snatch. And it's also the rules that are being expressed when the little toddler bends over to pick up his toy truck. Okay? The toddler won't do that after going to preschool or primary school because he's now starting to develop movement dysfunction and his biomechanics will actually change. They are corrupted by modern society. Okay? And so we relentlessly pursue, in my organisation and our back injury education, we relentlessly pursue virtuosity in movement. And when I use the word virtuosity, I mean being exceptionally good at the unexceptional. Okay, and that's very realistically achievable. Just being really good at sitting down in a chair, being really good at standing up, being really good at bending over to brush your teeth. Okay, and we do that through repetition of retraining motor patterns. Okay, and we do it in grandma, we do it in teachers, we do it in athletes, we do it in teenagers who have back pain. And it takes time. It takes time. It's a motor pattern retraining. Just like if I said to you, hey, let's go learn how to juggle, or let's go learn how to hit a nice one wood and get the ball straight down the middle of the fairway. You're not going to learn that with one bucket of golf balls. You're going to need to get a coach, a good golf coach, and he's going to teach you motor pattern training. And that's the same principle when we're teaching motor pattern rehabilitation, but for something a little bit more important than golf. It's for the health of your lumbopelvic spine. That's what I would be advocating for QAS. I would be advocating that for paramedics to really understand the biomechanical proficiency of moving in your everyday life activities, regardless of whether they are trivial tasks like bending over to empty the dishwasher, brushing your teeth, or whether they are to bend over and pick up a heavy stretcher with a 200 kilogram patient in it. That is the key element of not only recovering from an injury, but preventing an injury and also being able to develop that high level of functional capacity that is a requirement for your profession. Okay, thanks very much.
That's it.
Thank you, mate.
Even though there were backs there.
Cheers.
Thanks very much. Home stretch, we've got a short break now for 10 to 15 minutes. Following the break, we'll have two speakers and a Q&A. So we'll be back here at